Okay, good morning. Sorry for the feedback. I think we can start. Am I loud and clear?
Yes, Mutare, you're loud and clear.
Hello?
Yes, Mutare, you're loud and clear.
Hello? I don't get a feedback.
We are getting you
Lawrence,
loud
are you
and clear.
getting me?
Yes, Mutale, we can hear you.
Okay.
If you are not hearing us, have you muted yourself?
Okay, let's move. So we are going to discuss about FNA of the kidney and the adrenal gland. Actually, as per yesterday, we had thought that we would finish this in one presentation, but actually kidney FNA seems to be very big for that case, and I think I'll cover some part today, and then the remaining part will be covered, I think, in another presentation. But we can move forward. So for introduction, let's look at first at the kidney FNA, and here we say FNA aspiration biopsy for the kidney is a valuable diagnostic modality for radiographic intermediate mass lesions, for workup of systematic diseases like metastatic lymphoma or infections, and it is also very important for establishing a malignant diagnosis in non-surgical candidates. And we realize that in recent advances, most especially in imaging, interventional radiology, and cytologic auxiliary techniques, have actually advanced the accuracy of renal NFA, and malignancies can actually be easily diagnosed conclusively, sometimes using the advances in radiology to identify tumors. But sometimes the challenge is on distinguishing these tumors to tell whether they are malignant or they are benign, and sometimes to specifically categorize them whether they are mucinous or not. That's where sometimes we involve a technology of having FNAs and confirm the real categorizations of these tumors. So judicious application of immunohistochemical and genetic molecular techniques has also made subclassification of renal neoplasms very possible in FNA samples. So indication is for renal FNA. We realize that it is indicated to have renal FNAs in cases where radiological findings are inconclusive. Just like I said, a fine lesion could have been identified, but to confirm, we may need an FNA, like for example in cystic lesions, small solid masses, and then bilateral masses. So radiological nephrectomy is also contraindicated, and in this case we look at in cases of unresectable renal cell carcinoma, possible metastatic tumors. We look at the possibilities of having a lymphoma And then also what we need to put in consideration is patient with significant comorbidities, sorry for that. But look at patients with the significant comorbidities where we may need to draw a clear line. So continuing with the indications, we also look at conditions of partial nephrectomy, where it is very important. And then we look at cryoablation therapy, and also in infection, where we suspect that probably it could be as a result of an infection. So how do we collect specimens, and how do we prepare our samples for kidney FNA in this case? So FNA biopsy of the renal masses is now one of the most performed peritoneously, and by radiologists using computed tomography, or what is commonly known to as a CT scan, and less commonly ultrasonography, and rarely magnetic resonance imaging, or to actually identify the lesions. So the most common radiological method which we use is actually the CT scan, and followed by ultrasound scan. Actually, in this, like in Africa here, this may be the opposite, because there are very few places where we have a CT scan, and in this case we always use the ultrasound scan system because it is readily available, though the CT scan would give us more diagnostic and reliable results than the ultrasound scan, but sometimes circumstances dictate. So slides are air dried and stained with the Diffquick or other alcohol fixed, and stained with the PAP or hematoxylin and eosin. Diffquick and PAP stains are both helpful and complementary to each other. We shall see cases where cells are more clear in Diffquick than in PAP, and again we all know that for Diffquick this is a very quick method, just like the name goes, Diffquick. So in cases where we want to have very quick results, we want to evaluate whether our aspirate has actually harvested a good number of cells. In that case, then a Diffquick would be very important, because it will give us a clear judgment in a very short time. So the Diffquick stain is valuable for one-site adequacy evaluation, which significantly increases the success rate of needle biopsies, and it also is useful in assessment of the cytoplasm texture, bringing up the papillary architecture and the cytoplasmic hairline globules in certain type of epithelial renal tumors. So PAP stain is also very helpful in delineating the nuclear details, as we all appreciate that we actually have clear images and clear staining when we use PAP, and clear identification of the different features within the cell. So cell blocks and thin preparation of slides are useful for immunohistochemical studies. Cell blocks and core needle biopsies taken with a larger needle of 18 gauge or larger will provide the benefit of tissue architectural features. Immunohistochemical studies can be helpful in separating metastatic tumors from primary renal tumors and subtyping renal epithelial cell neoplasm in some settings. We shall be looking at a number of these neoplasms, and sometimes on other auxiliary tests that we can employ, like a histochemical test, and then we see how we can differentiate them based on immunohistochemical tests. So however, there are other considerations which overlap between immunohistochemical expression among different renal cell carcinomas. Therefore, results of a panel of markers must be interpreted in conjunction with the clinical presentation, cytomorphology, as well as molecular genetic information if available. So molecular cytogenetic techniques play an increasingly significant role in subtyping of renal cell carcinomas and confirming the diagnosis of certain types of mesenchymal tumors and lymphomas. So let's look at the accuracy and the adequacy. And in this case, we state that although renal FNA is a safe and accurate diagnostic modality with a high sensitivity of about 75 to 92% and specificity of 91.9 to 99, in experienced hands, the use of a combination of a fine and large nodule has become a trend in many medical centers. So false positive diagnosis commonly result from misinterpretation of benign hepatocytes, adrenocortical cells, and normal renal parenchyma, as well as renal cell carcinomas or uroethelial carcinomas. The most common false negative diagnosis is a sampling error of a cystic renal cell carcinoma. And in the contemporary era of frequency detection of small renal masses, the diagnostic accuracy of needle biopsy remains higher than 90%, albeit the rate of biopsy failure has increased as a result of inaccurately targeting the mass, especially the one with smaller than 1 centimeter. So serious complications from needle biopsies are extremely rare. However, tumor infection and hematoma have been reported in some cases. So as usual, we always need to understand the normal elements before we get to know the abnormal, as actually this helps us to make a good diagnosis and interpretation of the features we encounter in making out examinations and looking at the slides. So the normal glomeruli and renal tubular cells appear on FNA smears when the biopsy needle is inevitably transverse. The normal kidney parenchyma will appear, and usually the renal cortex, and especially when a small intraparenchymal region is targeted. So when we are carrying out these FNAs, these samples would either be targeted when we actually have identified a specific mass, either using the previous methods when they're doing ultrasound guided or CT scan. And in this case, this is what we call the targeted FNA. And then we have the untargeted one, where a sample can be picked from any part of the organ or the tissue where we have nothing to target, but actually we just want to pick the sample. So it is extremely important not to overinterpret these normal elements as neoplastic, though sometimes they may present with some cell reactions and moderate atypia, which may want to mimic the malignancies. But with experience, I think we can be able to draw a line between these two, looking at different factors and morphological features that we use to identify malignant cells, and maybe in conjunction with other auxiliary tests like immunohistochemistry and cytogenetic typing, which may help us to draw lines between the different cells. So glomeruli and tubular cells often coexist in relatively hypocellular smears, and the glomeruli are densely cellular multilayered and lobulated globular clusters with capillary loops. We shall look at some. So at scanning magnification, they mimic vascularized cells. They mimic vascularized cellular clusters of papillary renal cell carcinoma and angiomyolipoma. So we have illustration is in this slide, and here we look at how these cells appear in a slide. If I can get my pointer here. Okay, so we are looking at the normal kidney elements in this case, and we have image A on our extreme left, and then we have B on our right. So for A, we can see the glomerula with the two lobulated structures on the right. These are the two lobulated structures here. We have one here, and then we have another one here. And the tubular cells, which are proximal tubular cells on the left, and we can easily see these are the cells we are referring to. We are seeing these cells. These are not lobes, but these are cells we are seeing here. And we have even some cells here where the arrow is on the left here down. On the right here, we can, where the arrow indicates, we have a small arrow here. Also, these are cells we are referring to, and these coexist in relatively hypocellular smears at scanning magnification, and this is a deep-quick staining technique. So in B, we have the glomerula characterized by densely cellular and lobulated globular clusters with capillary loops containing abundant red blood cells. So on our right, when we look at the background of this image here, we really see it has a lot of blood cells, red blood cells, WBCs. There are very many of them. So this is a glomeruli characterized by a hemorrhagic background. So still looking at the normal tubular elements, we have another image here, and in A we can have a look at the proximal tubular cells, which are on the right, and this is the cluster. Actually, if I can again get the pointer, on the right we have a cluster here, and this is what we are referring to, where we have small loose clusters of epithelial cells with ill-defined cell borders. They have a granular cytoplasm and bland round to oval nucleus. And again, we have the distal tubular cells, and this is on the left cluster on this image. So these are the ones we are referring to in this case, the distal tubular cells, which are small. Sorry, this is not the actual interpretation of this. I think I'm interchanging. So these ones here, actually the ones which are these are the proximal. These ones are the proximal tubular cells on the right, and they are characterized by being small, and we can see they are small compared now to these ones on our left. Loose clusters of epithelial cells with ill-defined cell borders, granular cytoplasm, and bland round to oval nucleus. When we look at these cells clearly, we can see they are oval, round, and then they are discohesive, and the margin of the nuclei is bland for that case. Then the distal tubular cells, and these are now the cells on the left. Here where I'm putting another line on the marking them out. So those are the cells on the left, which are smaller, They are more cohesive. Actually, when we see them, they are more cohesive epithelial cells with less granular cytoplasm than the proximal tubular cells under DQ staining. And then our image B on our right, here we can appreciate an intact distal tubular fragment which shows a long serpentine cast, and this is in a pap stain. So the serpentine cast is this one. I think getting its name from the word serpent. If we can look at how the morphological appearance of this, it somehow looks like a serpent. So I believe that's where it draws its name and referred to as a serpentine appearance. So let's now look at benign lesions. For kidney FNA, we are going to have a number of features that we shall look at.
Mutari,
Look at the
Mutari.
malignant. Yes, Hassan?
Yeah, on the previous image of the serpent,
Sorry?
the previous slide of the serpent something.
Yes.
Yeah, so so that's a tubal fragment. Okay,
Yes, Hassan.
okay.
Briefly, I think I request to get to pick my earphones
I
so to
had a
get the feedback. Let me pick the earphones for
okay.
that case. Okay, I think we can move on. So let's look at the
Yes,
cystic
can
lesions
move on.
of the kidney, and in this case we can say that renal cysts are among the most common masses forming lesions identified radiographically just like any other tumors, and most congenital cysts and other simple cysts are easily recognizable on imaging studies. On radiological or only radiologically atypical cysts such as the ones with the thickened septations and or thick walls are sometimes targeted on FNA. The smears are consistently hypocellular, just like most of the cysts we have looked at before, and contain variable number of histiocytes and macrophages. Lyse gangrines, ball-like spherical structures with rods and concentric rings, can also be found in cystic fluids, and these features can be very important to draw lines between the different tumors that we may encounter in our slides. But specifically the ball-like spherical structures, we shall look at them, or the Lyse rings, are very important in drawing line between the cystic lesions, specifically in the kidney, and other malignancies, or other lesions that we may encounter. So depending on the nature of cysts, few epithelial and or stromal elements can also be present. Cystic neophroma, a benign multilocular cyst neoplasm, is now considered as a part of the spectrum of renal epithelial and stromal tumors. They often yield reactive epithelial cells and all spindle stromal cells, and these are often look like ovarian-like, which could be mistaken for cystic renal cell carcinoma or angiomyolipoma or even sarcoma. Cystic clear cell renal carcinoma, especially at low grade, can yield only a few deceptively bland neoplastic cells and is visibly a major cause of false negative diagnosis in renal cytology. So here we can look at images demonstrating to us some of the cystic lesions that we have. And in A, we can look at the macrophage, which are very common. They are common finding of all cystic lesions, including renal cysts. And in our previous discussions about cystic tumors, we have encountered this, and in a cystic background, to be very specific, we encounter a number of macrophages, and in the previous, I think, tutorials we've been looking at the former macrophages as a distinctive feature in a cystic background. So even in this case of renal FNA, we encounter some macrophages. So in B still, we may observe the Lis gang rings, the ball-like spherical structures in variable sizes, with crystal-like rays from a central core. If I can put back my pointer. So these are the rings we are referring to. Sorry. These are the Lisganga rings, which are ball-like. They are spherical in structure with variable sizes, because if you can look at this one is smaller than this, and this is smaller than this. This appears to be the biggest. And then they have crystal-like rays. If we look, like for example, at this bigger one, we see something like radiation is coming out of the center here, and then they spread outwards. So we can appreciate with different crystal-like rays from the central core here, and then concentric rings sometimes may appear. In this image here, I'm not seeing them clearly, but with some images we see concentric rings like moving around, like how it may appear in some of my bodies if we have taken keen interest in really looking at them. So this can be better appreciated on cross section in cell blocks, and here we have an image where we are looking at the Lis gang ring. This is now histology, and really we can appreciate the rings. We can see the rings. This is a ring. Around here we have another ring. These are concentric rings. And then we have our radiolines still, which are also appearing to literally coming from the center, moving outwards. And this is a discard ring under H&E. That's how it appears. So still, we look at another feature for cystic renal cell carcinoma, and under abundant macrophage. I mean, this one is reflects the abundant macrophage in cystic cell carcinoma, and it can be really misleading. This is the image here. This is the cystic renal cell carcinoma, which can be misleading. And then in B, we have a rare group of epithelial cells with slightly enlarged nuclei compared to the macrophage nuclei, and the clear cytoplasm can easily be overlooked, and this is in a pap stain. So when we look at this one, we can easily see the cytoplasm appearing. Sorry, if I can get back to the previous slide. So we can see the cytoplasm is clear. We look at the cytoplasm nuclear ratio is also not that so much, but the nucleus appears to be a little enlarged than the normal one, so it may be confusing, but actually it is not malignant for that case. So we look at benign lesions, and one of the benign lesions we are going to talk about here is what we call the oncocytoma. And the oncocytoma is a benign tumor of the oncocytes, which are a large epithelial cells with mitochondria-rich granular cytoplasm, comprising approximately of about 5% of all renal tumors. It occurs more frequently in men, with a peak incidence in the 7th decades of life. And because of the lack of its typical central scarring appearance on image studies, in some cases oncocytoma is often targeted for FNA. Aspirates are usually at least moderately cellular, composed predominantly of isolated cells, with small clusters and occasional large tissue fragments. The oncocytes vary in size and are uniformly or polygonal in shape. Their distinctive features include well-defined cell borders, abundant granular cytoplasm, and round eccentrically located nuclei with prominent nucleoli like the pomegranate seeds. There is binucleation and nuclear polymorphism. Binucleation and nuclear polymorphism are not common, but the nested architecture of tumor cells are a characteristic feature and helpful in clue of an oncocytoma. And this can be appreciated sometimes on the cell block sections. So the primary differential diagnosis is a chromophobe renal cell carcinoma. So nested tumor cells, round nucleus, and lack of perinuclear halo, they favor the oncocytoma diagnosis. In difficult cases, the Hall's colloid ion stain would be helpful. Oncocytomas show negative reaction or focal apical positive reactions in this case. In contrast, the chromophobe RCC shows a diffuse positivity. A positive S100A immunostain also supports the diagnosis of oncocytoma. However, a negative staining in small biopsy does not necessarily exclude the diagnosis, since S100A staining can be patchy in that case. So cytologic features, we realize that oncocytomas are moderately cellular and smears actually have also predominantly isolated cells. Cells may appear polygonal and variable in size. We may also see eccentrically located nuclei and often nucleated, round nucleus, granular cytoplasm, and well-defined cell borders. Binucleation, we said it is rare, but doesn't mean it doesn't exist. It may appear. And then nested tumor cells on cell blocks are very important. Differential diagnosis and the problems which could be associated with diagnosis. So here we need to do a differential on chromophobe RCC. We also need to consider so much the clear cell renal cell carcinoma, the granular cell variant, papillary renal cell carcinoma, type 2 subtype, and then we'll also look at the tuberocystic RCC, and then inadvertently sampled hepatocytes have to really be taken in seriously. So we have images here illustrating to us how oncocytoma may be identified on a slide. And in B, we see an image under scanning power which shows the cellular smear with single cells, loose clusters, and large tissue fragments under deep quick staining. So we can appreciate the arrangement of these cells, how they are appearing, and these are actually representative of an oncocytoma. And under higher magnification, here in the image on our right, the one I've labeled B, we can appreciate the polygonal cells in variable sizes with eccentric clay located nuclei, granular cytoplasm, and well-defined cell borders, which are reminiscent of the pomegranate seeds if we have encountered some in life. So that's how an oncocytoma actually appears. And looking at it on a histology slide, we appreciate the nested architecture with loosely cohesive tumor cells which are surrounded by thin capillaries, and is best appreciated on a cell block section. Here on image D, we can also appreciate the Hell's colloid form, the Hell's colloid ion stain, showing an apical staining pattern and also identifying the oncocytoma under histology. So away from the oncocytoma, let's look at the metanephritic adenoma. And we say the metanephritic adenoma is a rare benign renal epithelial neoplasm and commonly occurs in women in their 50s and 60s. These tumors are well circumscribed and range widely in size from a few centimeters to as large as 15 centimeters. The aspirate smears are usually distinctive and show numerous short tubular structures and tight ball or actin-like structures which are often attached to ends of the tubes. These tubular or acinar structures are composed of tightly packed and uniformly balanced cells which have scant cytoplasm, ovoid nuclei with fine chromatin, and inconspicuous nuclei. Some bodies and stromal materials may be present. Mitosis, nuclear tipia, and necrosis are usually absent in these cases. Looking at the cytologic features, in this case we expect to have hypercellular smear with short tubular structure and tight ball-like or the actin-like appearance. We also expect to have tightly packed and uniformly bland cells with scant cytoplasm, and occasionally we may encounter samoma bodies. Differential diagnosis. So differential diagnosis done with papillary renal cell carcinoma, and then the Williams tumor, the epithelial or tubular is dominant. In general, a panel of antibodies including the WT1, the CK7, AMA, CR, CD57, and epithelial membrane antigen would be significant to distinguish MA from papillary renal carcinoma and WT. MA tumor cells are positive for WT1 and CD57 and negative for CK7 and EMA and AMACR, which distinguishes MA from papillary renal carcinoma. So these are other auxiliary tests which can be done to make a distinction between these cells, as cytologically they may present with similar features or may draw inconclusive diagnoses, but we need to conclude. So most Williams tumors have a triphasic patina characteristic, which is illustrated by blastomer cells and these are small blue and mitotically active cells, and epithelial components and areas showing mesenchymal differentiation. Only the WTs with prominent epithelial differentiations would enter the differential of MA. Although both MAs and WTs show nuclear expression of WT1, which is an immunohistochemical stain, their pattern of expression, however, are different. Like, for example, in the MA, we shall see a strong diffuse staining, whereas in WT will present with variable staining depending on the area of differentiation. So we have an illustration of the metanephritic adenoma, or one abbreviated as MA. So we have pictures in A and B as labeled, and these are illustrating to us cellular smears showing distinctive short lobular structures and tight balls which look like acin, or which are acin-like, lined by uniformly bland cells with scant cytoplasm. So I think we can appreciate, we can see the ball-like appearance or the acin, like where I'm putting the cursor on my image B, and they are really lined by cells. These are looking like acin, or they could be tubular. We can appreciate them here being tubular. Here we can also appreciate the morphological appearances. So we have also another illustration here of MA, or the metanephritic adenoma, and in the image C we can appreciate the numerous small tubular acin structures which are embedded in hellenized stroma, and these are best seen in cell block material under H&E in histology. So we can really appreciate the acinic arrangement in tubes. There are very many of them. And then we see a strong and diffuse immunostaining patina for WT1, which is really characteristic of metanephritic adenoma. So another benign tumor we look at is the one we call the xanthogranulomatous pyelonephritis, and xanthogranulomatous pyelonephritis is an atypical host response to the upper urinary tract, maybe by a bacterial infection, and it may present as a renal mass radiologically and needs to be confirmed by FNA so that it cannot be misdiagnosed. So the abundant form histiocytes, especially in aggregates, can be confused with cells of a clear cell renal cell carcinoma. The degenerated renal tubular cells may mimic cells from the oncocytoma. So the FNA appearance of XNP is more inflammatory and lacks nuclear atypia for that case. The histiocytic nature of the lesion cells of XPN can be confirmed by immunoreactivity of CD163 and CD68 in difficult cases where we need to draw fine conclusions. So we have an illustration expressing to us or showing us what the XP tumor can really appear in a slide, and in this slide we can appreciate the cellular smear showing predominantly inflammatory cells with the admixtiform histiocytes and degenerated epithelial cells. So we need to note that nuclear atypia in this case is absent. Under higher magnification, this is at low magnification. Here where we can appreciate the arrangement of the cells, we can see some cluster-like, and then we look at the background which is highly inflammatory. But under higher magnification, that's when we can be able to look into details and the morphologies of the cell and see whether we have the typical cell changes or not. So away from the benign, let's look at the malignant neoplasm, and we shall straight away begin with the renal carcinoma. And he said that the renal cell carcinoma is a malignancy of the renal tubules and represents more than 90% of all malignancies in the kidney in adults. Men are more commonly affected, and the incidence is higher in industrialized countries than in developing countries. I don't know the reason why, but that's what research has shown. Its risk increases with the tobacco smoking, arsenic exposure, and obesity. A majority of RCCs develop in the background of hereditary cancer syndrome and end-stage renal disease. So the specific forms of hereditary RCC include the von Hipp-Landau, clear cell carcinoma, we have the hereditary papillary renal carcinoma, and then the Birt-Hogg-Dube oncocytic neoplasm, and the hereditary leiomyomatosis renal cell carcinoma. The two distinctive novel tumors linked to end-stage renal disease acquired cystic disease associated with renal cell carcinoma and clear cell papillary renal cell carcinoma. Since approximately 1/3 of patients with the RCC present with the metastasis and the solitary metastasis at unusual sites, like for example the thyroid, salivary gland, pancreas, which is common, it is essential to be familiar with the cytomorphological spectrum of each subtype of renal cell carcinoma for accurate diagnosis of metastatic renal cell carcinoma. So precisely, subclassifications of RCC is also becoming increasingly important as ineffective molecular targeted therapies and being developed for specific types of RCC. The latest World Health Organization classification of renal carcinoma, which was done in 2016, highlights the close relationship between the morphology and the genetic abnormalities of each clinically distinctive type of renal cell carcinoma. Notably, several distinctive forms of RCC, including hereditary leiomyomatosis and renal cell carcinoma syndrome associated RCC, succinate dehydrogenase deficiency RCC, tuberocystic RCC, acquired cystic disease associated RCC, and clear cell papillary RCC are newly recognized in the WHO guidelines of 2016. So the Fuhrman nuclear grade is widely used in histology and one of the prognostic parameters by nuclear grading in FNA or core needle biopsies remain controversial in this case. Undergrading and inter-observant variability are common caveats that are encountered even in other tissue examinations, because different observers, different pathologists may have different interpretation as different atypical reactions. So the following subtypes of malignant renal epithelial neoplasm are discussed, and here we look at the cytogenetic abnormalities and the immunoprofiles, which can be used to facilitate the subclassification at the same time. And in this case, we have the clear cell clear cell malignancies or renal cell carcinomas. We have the papillary RCCs, we have the chromophobe renal cell carcinomas, we have the sarcomatoid, and the list continues. As you can see, we shall be looking at some. So we have a table here categorizing clearly the cytogenetic and the immunoprofile subclassification of some renal carcinomas. Like for example, here if I can mention about the two, the rest we shall find time to look at them. We have the RCC subtype, and we have the cytogenetics, and then the immunoprofile for categorizing different carcinomas. So number one here we have the conventional or the clear cell renal cell carcinoma, and cytogenetically here we expect, the diagnostic part of it is that we have a deletion at position 3 at the P arm of the chromosome, and then the immunoprofile here with the RCC, we shall have the RCC positive, CD10 will be positive, AMCRA will be positive, CA9 will be positive, and then the rest of the carcinomas can also be categorized based on these immunoprofiles and cytogenetic profiles. So looking at the cell, the clear cell renal carcinoma, or commonly called as known as the conventional renal cell carcinoma. In this, we appreciate that this accounts for approximately 2/3 of all renal epithelial neoplasm. It is characterized histologically by large, clear, and all granular tumor cells nested within the network of thin-walled blood vessels. Hemorrhagic necrosis, calcification, and cystitic degenerations are common, and these features account for its characteristic appearance on imaging studies and the typical blood smear on FNA samples. The cellularity of aspirate is highly variable, ranging from cellular smears with clusters and sheets of tumor cells to merely only blood. In later cases, the tissue fragments can sometimes be covered in cell blocks sections. Deeper level sectioning can be rewarding in getting the diagnostic tissue fragment in blood cell block. In cellular smears, tumor cells are commonly seen in association with the transgressing blood vessels, which can mimic a papillary renal cell carcinoma. The tumor cells are often larger than normal tubular cells, at least 2 times the size of a normal cell, with a lower nuclear to cytoplasmic ratio. The distinctive feature here is abundant, clear to fine vacuolated cytoplasm, rich in glycogen and lipids, which are best appreciated on the deep quick stain. The cell borders are often irregular and indistinct. The often eccentrically located nuclei are round and contain variable sized nucleolus. With the presence of all characteristic features, diagnosing clear cell renal carcinoma based on cytomorphology alone can reach a high accuracy of greater than 90. The primary differential diagnosis of low-grade clear cell carcinoma is normal renal tubular cells and adrenocortical adenoma, whereas that of high-grade RCC includes adrenocortical carcinoma and epithelioid angiomyolipoma. So here we have an image which is demonstrating to us or how a clear cell renal cell carcinoma appears like. So we have images B and A, where we can see tumor cells arranged in sheets or in clusters with transgressing thin papillaries. We still have images here illustrating us to the same. We have one of cytology and then we have one in histology. So you see on our left we have small clusters of tumor cells which can be displayed like a butterfly if you look at their appearances, and the tumor cells are characterized by low nuclear to cytoplasmic ratio, round nuclei with the prominent nuclei, abundant clear to granular cytoplasm with numerous small vacuolations and ill-defined cell borders. We can appreciate the vacuolation here, but to identify clearly or to appreciate the borders, it would be better if we look at them under higher magnifications, but we can be able to look at the vacuolations here and possibly the granular background, which can also be appreciated under higher magnification. So under histology, we can see the tissue fragments which can be sometimes recovered in cell block sections in a blood aspirate. So this is so much clear with the red blood cells, many of them. Here we are putting the cursors and we can see some infiltrating the tumor, but that's a good illustration of the tumor. So auxiliary studies that we may employ in this in the clear cell RCC, we have RCC positive CD10, EMA, ACR, and CA9, and they are negative for CK7 and CD117. Cytogenetic, here we expect the deletion on chromosome 3p, the site of tumor suppressor gene involved is involved in von Hippel-Lindau disease. Cytologic features, it is moderately cellular, blood smear, and cell is moderately cellular, blood smears, and cell blocks. When examined, they can present all these features and are clearly appreciated. Cohesive cellular clusters with or without blood vessels can be seen, and then we also shall appreciate the low nuclear cytoplasmic ratio, large tumor cells with uneccentrically located nucleus, denucleated, and round nucleus, vacuolated pericytoplasm, and ill-defined cell borders. Occasionally, they could be hyaline globes also present. So we look at another malignant carcinoma, and this is what we call the papillary renal carcinoma, and this one represents 10 to 15% of the renal cell carcinomas, and is defined by presence of papillary architecture in at least 50% of the tumor. Papillary renal cell carcinomas can be multifocal and associated with the renal papillary cortical adenomas, which are which are less than or equal to 1.5 centimeters in size. So owing to its diverse morphology and overlapping features with other subtypes of renal cell carcinomas, the rate of correct subclassification of papillary RCC is usually approximately 50%. The smears of papillary RCC are typically hypercellular with large complex papillary clusters and few single cells at scanning power. The type 1 papillary renal cell carcinoma, the tumor cells lining the fibrofascicular strokes are small, cuboidal, and uniform, and have bland, sometimes grooved nuclei and scanty cytoplasm, whereas type 2 papillary RCC, the tumor cells are large and have abundant granular cytoplasm and pleomorphic nucleolated nuclei. The former macrophages within the vesicular cores and all singly dispersed intracytoplasmic hemosiderin depositions and large spheres of tumor cells are additional characteristic features for papillary RCC. Some morphological variations, such as with clear cell features and focal mucin production, pose a diagnostic challenge for subclassification. In such cases, immunohistochemical studies with panels like that of CK7, AMACR, and CD10 markers, and all fluorescence in situ hybridization studies would be helpful to make a final diagnosis. So when you look at auxiliary test, we have these markers that we can actually employ, and going for cytogenetics, a trisomy of chromosome 7, 16, and 17 and loose chromosome Y are very important and significant in this case of papillary renal carcinoma. Cytologic features, we mentioned some, but we expect to have a hypercellular smear, papillary clusters of tumor cells with the arborizing vessels, former macrophages, hemosiderin deposits in tumor cells. We also appreciate the two types of tumors, type 1 papillary carcinoma with the uniformly small cuboid cells with bland grooved nuclei and scanty cytoplasm, and then the type 2 where we appreciate the large pleomorphic cells with the round nucleated nuclei and abundant eosinophilic cytoplasm. So we have some images here in reference to the papillary carcinoma, and in A under scanning power we can see the hypercellular aspirate with the arborizing papillary structures, and the tumor cells lining the fibrovascular strokes are small, cuboidal, and uniform in type 1. So this is under low magnification, but we can appreciate the fibrovascular strokes which are lined by cells. So in B, I think this is where we can actually appreciate the shape of the cells, them being cuboidal. So in B, we can also appreciate, this is under pap stain, where we see the large pleomorphic with abundant granular cytoplasm, and this is appreciated in type 2 papillary RCC. So looking at another image with abundance of former macrophages and then deposit of hemosiderin pigments in macrophages and all tumor cells, and if we can see spherical clusters, additional characteristic features. So we have clusters, and then we have depositions of hemosiderin in some cells, like in this macrophage here. We can see this hemosiderin deposition. I can see another one here. So those can be appreciated. Another malignant carcinoma of the kidney is one we call the chromophobrenal cell carcinoma, and this accounts for 5% of all RCCs. Here we appreciate that aspirates are at least moderately cellular and contain both dispersed and small clusters of tumor cells, I beg your pardon to attend to something small, then I come back. Yes, we can continue. So in this case, the aspirates are at least moderately cellular and contain both dispersed and small clusters of tumor cells. Two principal types of tumor cells are intermingled: the large polygonal cells with the abundant pale fluffy cytoplasm, and the small granular cells with a higher nucleus to cytoplasmic ratio and more granular cytoplasm. And then the nuclei are centrally placed, they are hyperchromatic and with an irregular, often wrinkled nuclear membrane. The nucleation is common. Pseudonuclear inclusions are occasionally seen. And in this case, two distinctive features of chromophobe RCC are the rigged, often thickened cell membrane and the perinuclear halo, giving a cholecytic appearance. The blood vessels, though not prominent, are also present and usually loosely associated with the tumor cells. Should the distinctive features of the chromophobe RCC be absent, it could really be very difficult on cytologic grounds alone to separate it from the oncocytoma or the conventional RCC, especially the eosinophilic variant. Auxiliary studies such as the Hals ion stain, immunohistochemistry, and cytogenetics in this case could be very helpful to come up with a conclusive diagnosis. So auxiliary studies may include the chromophobe RCCs, which are positive for CK7, AMACR, and negative for RCC and CD117. Cytogenetics, this is as a result of the monosomies for chromosomes 1, 2, 3, 6, 10, 13, 17, and 21. Cytological features may include moderately cellular smears with mainly single cells with well-defined cell borders, and two types of cells where we may appreciate the large polygonal cells with abundant pale fluffy cytoplasm and smear granular cells with higher nucleus to cytoplasmic ratio and more granular cytoplasm. We may appreciate the perinuclear halo, which may appear coilocyte-like, frequent binucleation, variation in nuclear size, hyperchromasia, and the wrinkled nuclear membrane. So we have images in reference to all what we have talked about as regards the chromophobe adenocarcinoma. And to be direct here on this image where I'm putting the cursor, we can really appreciate the perinuclear halo, which is appearing like a coil site, but actually these are not coil sites, and which is a key feature in diagnosis of the chromophobe adenocarcinoma. So we have another carcinoma we call the clear cell papillary renal carcinoma, and this is a newly recognized entity occurring in patients with or without end-stage disease, and is included in the World Health Organization guidelines up as 2016 as a distinct type of renal cell carcinoma. It is the fourth most common subtype of RCC and is clinical pathologically distinctive from birth, clear cell RCC and papillary RCC, with the CCP-RCC which has likely been misdiagnosed as in the past. Characteristically, the CCP-RCC is composed of cuboidal or columnar cells with clear cytoplasm and low-grade nuclei in a peaked fence-like arrangement. It is also very important to recognize CCP-RCC as it is associated with an indolent clinical cause with extremely low metastatic rate. So away from the cytological tests and histological tests, we can look at other auxiliary tests where we see CCP-RCC expressing the CA9 in a characteristic cup-shaped staining pattern, which differs from the box-shaped staining pattern seen in clear cell carcinomas. And we also appreciate that the CCP-RCC is also diffusely positive for CK7, but unlike in CCRCC, and negative for AMA-RCC and CD10, unlike in PRCC. No specific chromosome abnormalities have been studied in the case of cytogenetics to be related or associated with this as of now. So cytologic features may include the nested three-dimensional clusters, columnar cells or polygonal cells. We may have clear cytoplasm with the small vacuoles, low-grade small round to oval nuclei with fine granular chromatin, and the nuclei is located at one pole of the line of cells. So we have some images attesting to what we have been talking about, and in these images we can appreciate the image one on our left, that there is a three-dimensional cluster of cuboidal tumor cells with a centrally located there's low-grade nuclear and clear there is validated cytoplasm, and this was a touch preparation of a core biopsy and stained under different. We can appreciate the core needle biopsy showing papillary or tubular architecture of columnar and cuboidal cells arranged in a stripping small round nuclei located away from the basement membrane, actually in what would appear like a picket fence like arrangement, and clear cytoplasm under H&E. So in the interest of time, we may not actually go on discussing every type of these renal carcinomas. So I've listed some of the remaining carcinomas, and I request that we find the time at our own pace to read about these other carcinomas. I highlighted this red one because I'm very sure we have covered in our previous tutorials. We covered urothelial carcinoma with Professor Diaz, maybe, and the lymphomas also we covered some. So at our own interest and for our own good, I think we shall find time to go through them, read and understand them better, because if not so, we may spend the whole day discussing these different carcinomas because there are many. So amongst the many others, we have the sarcomatoid renal cell carcinoma, we have the renal translocation carcinoma, the mucinous tubular and spindle cell carcinoma, collecting duct carcinoma, and the list continues. So I really don't know, but I wanted to stop here for today with the kidney, and maybe on another presentation possibly tomorrow I can begin from here with the adrenal gland, and the remaining parts of the discussion, and then we call it off. I really don't know what my colleagues suggest, but I see it is coming to 9, and I wish to give people time to go to church. So I'll end here for now, and I welcome